So good afternoon to one and all. First of all, I'd like to thank the M.K. Ravindran sir and the whole team of WhatCon for giving this wonderful opportunity to talk on this podium. Greetings from Department of Orthopedics, Calicut Medical College. So my brief is to talk on terrible triad of elbow, whether it is still terrible or is there any improvement. So greetings from Department of Orthopedics, Calicut Medical College. So in the coming 10 minutes, I will be just taking you through some of the relevant anatomy, biomechanics of cerebral triad, and what are the management principles that you should be following in the current 2024, and what are the current concepts in the treatment. So if you see the elbow joint is basically asymmetrical joint, just like a knee joint. It has a medial and lateral part. The middle part has got, as you see, the middle part is the ulnohumeral part. The ulnohumeral part is very congruent. Around 270 degree of the trochlea is covered by the upper part of the ulna. Whereas if you see the lateral part is basically only 1/3 of the capitulum is covered by the radial head. So it's relatively more unstable. So here, hence, the tissues, the soft tissue structures are more important on the lateral side compared to the medial side. So that's why you have the lateral collateral ligament and common extensors play more role to maintain the stability of the lateral part of the elbow joint compared to the middle part of the elbow joint. As we all know, the stabilizing factors of the elbow joint can be divided into primary or secondary. The primary mainly that you should remember, that's the ulnohumeral joint. That gives the maximum stability to the joint. Then you have the MCL and the LCL, and the secondary stabilizers are the radial head, along with the muscles that cross your joint. That's anteriorly you have the biceps, posterior triceps, that gives the stability. When you go back, so just to some anatomy, some biomechanics, the valgus stability is given by the medial collateral ligament as well as the radial head. So either of one should be there to give maximum stability. Basically, if the radial head is there, you can see some of the part of the medial collateral ligament can be treated conservatively. Coming to varus stability, it is provided by a lateral collateral ligament and the anteromedial facet of the coronoid. So that's the medial part of the coronoid. That's the bony structure. So there is one bony and one soft tissue structure. Similarly, the axial stability is provided by, that means the anteroposterior stability is provided both by coronoid as well as radial head. So these are the three things that you have to keep in mind when you check for the stability or treat the instability in the elbow joint. Now when you come to an elbow injury, everything is not a terrible triad. So elbow instability is a spectrum of injuries. So it starts from terrible triad. It can be simple or complex. Simple means there is only soft tissue injury, there is no bony injury. When it complex one has a spectrum of injuries. It can be just a terrible triad, it can be posteromedial rotatory instability, it can be a fracture dislocation, transforaminal fracture dislocation, or hypomontagia. So what we will be discussing here is basically the terrible triad. So we have, what is a terrible triad of elbow? We all know that from the UG days we know it's elbow dislocation, radial head fracture, and coronoid fracture. But from a consultant point of view, you should be knowing more. So basically, coronoid fracture, in a classical terrible triad, you have fracture of only the anterolateral part of the coronoid. So I will be showing you in the next picture series. So only the anterolateral part is classically fractured, and in the radial head also, it's only the anterolateral part is classically fractured in case of a terrible triad. So more than the bony injury, in case of a terrible triad, the more important thing are the soft tissue structures. As we all know, the pathology from the Horis circle, the pathology, there is a disruption of tissues from lateral to medial. So both not only the muscular structures, but the capsule also disrupts from the medial to lateral to medial. And finally you get the dislocation. So it's a start from a PLRI to purge to complete dislocation. So when the MCL is also completely gone, you get total dislocation. So that's a pathology. So it's very important that you remember not only the bony tissue injury is there, the soft tissue injuries are equally important or more important than the bony injuries. Because we neglected the soft tissue injuries in our previous years, that's why the injury was considered terrible and we get a terrible result. So why so terrible? Because the injury was unstable and it led to joint incongruity. So that led to later arthritis. And all the fragments, as I told you, it's not the complete radial head that is fractured or complete coronoid that is fractured. So all the fragments are very small, are difficult to fix and not fixed usually. And in spite of a good treatment, many of the patients didn't do well. Either they would develop some stiffness or instability. And sometimes the fracture gets dislocated within the cast itself. So that's why it was considered as a terrible triad. Okay. As you can see here, the joint goes for instability or small fragments are not well fixed, or in spite of fixation you get arthritis. So this was the classical practice, one of the classical papers by Jesse Jupiter and David Ring way back in 2002, which had a long follow-up of 7 years of 11 patients. Out of these 11 patients, 7 patients didn't do well, and they conducted that it's difficult to treat this injury and may need hinge fixator in many of the cases. So that was a picture in 2002. Now let's see what's changed. So basically, one important thing that you should be doing when you get an elbow instability or a suspected cerebral tract case is examination and anesthesia. So you look for the, as I told you, there's a soft tissue injury is a major component. You look for the integrity of the soft tissues, both at 0 degree and 30 degree, just like you look in the knee joint, whether the collaterals are for varus and varus stress testing. So the varus stress testing you can do just in supination. So that checks the stability of the two things, the LCL and the anteromedial facet, as I told you previously. The valgus stress for the MCL you do in pronation basically, because when there is a radial head fracture, if you do in supination, you can get a pseudo laxity. So you just pronate so that the posterior part of the radial head comes anteriorly, and you get easily test the MCL. So the valgus you do in pronation, varus you do in supination. So you can see the opening, as you can see, and then you look for the stability of the elbow joint in full range of movement, from full flexion to full extension, whether the elbow is stable. So as you can see, from flexion, as it comes in extension, it gets dislocated. So you want to check for the stability up to last 30 degrees of extension. If the elbow is stable up to last 30 degrees, in the till last 30 degrees, majority of the cases can be treated conservatively. If it dislocates before 30 degree, that means there is a component of a complex dislocation, and you need to do something more surgical. So this is one important sign that can help you to find out the instability. This is a drop sign that's seen in the lateral view of the X-rays. A recurrent drop sign. The patient comes to you with follow-up with an X-ray. 1 week, 2 weeks, you see this drop sign that indicates that the elbow is not properly reduced. So that I have to keep in mind. Now coming to the management, as I told you, the first part is you have to not only don't treat the X-rays basically, for all the suspected all the complex cases you need a CT. So both the axial, coronal as well as 3D. That gives you the correct picture of the fracture. This is a fracture, so the management starts with the investigation. The important investigations are the X-ray as well as CT. So all the complex cases you have a CT scan. Okay. So the basic line of the basic principle of management is you start from inside, go outside. So inside, the innermost structure is your coronoid. You start with the fixation of the coronoid, then go to the radial head, take the LCL and common extensor origin, and finally and rarely you need fixation of the medial side. So that's the basic principle of management. So let's start with the coronoid. Does the coronoid always needs to be fixed? So this was a paper in 2014 where by Surendran, where they suggested that type 1 and type 2 morae doesn't need fixation. But let's see what's correct scenario. So coronoid provides around 60% buttress to the anteroposterior stability, as you can see here. So this is a paper from Adam Watts from Wrightington, where they say the elbow is into 3 columns, just like in the wrist. The lateral column is by your radial head. The middle and medial column is produced by a coronoid. So as you can see, the anteromedial facet of the coronoid is around, the area of anteromedial facet is almost similar to the area of radial head. So it's almost equivalent. And if you see, if there is a break in either the lateral or the medial column, the elbow becomes unstable. So only if there is a fracture of the middle column, the stability will be maintained, because the lateral and medial columns are intact. So as you can see, the middle column is your anterolateral facet and the medial column is your anteromedial facet. So if there is a fracture of only the anterolateral facet, you can treat it a little conservatively. So that means only small chip fracture. Now if you go into details of the CT scan, from the CT scan, these are the various types of coronoid fractures that can happen. So this is just a tip fracture that is commonly seen with your cerebral tract or the anterolateral facet fracture. So the size of the anterolateral facet differs. It can be a small tip or it can be a little larger tip. And when the thickness of the coronoid increases, what happens? When the thickness of the coronoid increases, the coronoid gives attachment to your capsule. So where does the capsule arise? And when the thickness increases more than 20 to 25%, the capsule attachment comes. And as I told you, capsule is one of the major stabilizers, one of the important stabilizers of the elbow. As you can see here, that's the attachment of the capsule begins around 5 mm from the tip, and the brachialis begins around 10 mm from the tip. So whenever you find a fracture of the coronoid, if the size is more, around 20-25%, something more than the tip from the CT picture, from the 3D CT picture, it indicates that there is injury to the capsule also. So you need to fix that. So just a tip fracture, don't take it lightly. This is just like a Sibin fracture of your knee joint. A Sibin fracture indicates it's likely to be an unstable knee joint. So various techniques for fixation, I won't go into the details. The commonest one, if there is a small tip fracture, the commonest one that you do is a lasso loop technique and tie it on the bone. You can do arthroscopically, and if the size is large, you can go for a plate fixation. But that's too much large size is rarely seen with cerebral tract. Coming to the radial head, I won't go into the detail, the Balu will be discussing more. And you can depending upon the size, type of the radial head, you can go for fixation or replacement. Basic thing you have to keep in mind is that you don't overstep the radial joint if you are replacing it. Another important, so that's a bony part. We discussed about coronoid, then the radial head, now the soft tissues. The most important soft tissue that you want to know is the lateral collateral ligament. This is an important paper that discusses the functional anatomy of the lateral collateral ligament. So the collateral ligament, as we are only concerned about the lateral ulnar collateral ligament, this paper says that it's equally important that you reconstruct whenever possible both the annular and the radial collateral ligament. Because according to the paper, if you release only the anterior band, there is instability in varus only. But if you release both the anterior and posterior band, it leads to instability of the ulnohumeral joint. So whenever possible, in a fresh case, don't try to suture only the LUCL, but repair the annular ligament and the radial collateral ligament. This is the annular ligament that guides the radial head into the capitulum. Okay, and the LUCL just supports the radial head. So try to repair both. And whenever you go, iatrogenic don't try to damage the lateral collateral ligament. So usually the lateral collateral ligament can be ruptured anywhere, but most commonly it is ruptured at the attachment site of the humerus. So you can see a bald lateral collateral ligament, and can acutely repair. You can go through the site of incision, and usually there will be small damage when you see put a skin incision, but when you go deeper, you can see the whole of the lateral collateral ligament is completely totally bald, and you can fix it whole of the mass with using either anchor or a transverse sutures. And if that lateral collateral ligament can be rarely damaged in the substance, then you can use an internal brace for repair of the lateral collateral. They can go to any of the intervals. It can be Boyd, it can be between the ulna and anconis, it can be Coker between anconis and ECU, it can be Kaplan, or it can be EDC split. So if you are going through the Kaplan approach, beware of posterior introsseous nerve. If you are going through the Coker approach, beware of your lateral collateral ligament. So between Kaplan and Coker, these are the two commonly used approaches. The maximum exposure you get is with the Kaplan, the anterior part. In a terrible triad, you want to see the, and as I told you, it's the anterolateral part of the head of the humerus, head of the radius, and the coronoid. So you get best exposure with the Kaplan. The advantage of the Kaplan is that you can extend it proximally and distally. And you can see the tip of the coronoid also in this approach. Now how much can you extend proximally and distally? Now this is a good paper from Japan that shows the safe zone for extension proximally and distally from Sukeyama that came in JSCS. The lighthouse for your lateral approach, or the key point, is the lateral epicondyle. Find the lateral epicondyle, then extend it proximally and distally. The proximally, you are worried about the radial nerve. So the radial nerve, and distally you are worried about the posterior introsseous nerve. So as per this paper, the lowest point where the radial nerve can be damaged is around 8 cm above. And posteriorly, and in the lower half, the highest point where the radial nerve pin can be damaged is around 5 cm. So safely, you can go around 4.5 cm distally and proximal from the epicondyle. So around 4 to 4.5 cm is a safe distance. Another thing you have to keep in mind is that don't put your lever on the anterior half, on either side. So you put distally, you can damage the posterior introsseous nerve. Proximally, don't put higher lever. And keep your arm pronated. Whenever you pronate the arm, the pin distance increases. Okay. So coming to MCL, MCL is rarely need to be repaired. It's very rarely, it's the final thing that you need to perform. If the instability persists, even after repairing your lateral collateral ligament and the capitulum and everything. So when to fix an MCL? So let's see a situation. So this is a case of instability, a terrible triad, and it dislocates less than 40 degree. So you fix it, and you can see there is on valgus stress testing, there is medial opening up. So you replace the radial head, fix the lateral collateral ligament. Then again check for the lateral instability, the valgus instability. There is medial opening. And then again go and look for the range of movement. And when you extend it, again it is dislocated. So this is an indication the instability is persisting in spite of you fixing the lateral collateral ligament, in spite of you fixing the radial head. So in those cases, you have to go and do something for the medial side. So you can go either medially and fix the medial collateral ligament. Another option is you can go for an articulated X fix. So this is the situation, and this happens rarely if your fixation of the radius and the lateral collateral ligament is very good. And medially you have multiple approaches. The commonly used approach is an FCU split approach that depends upon which part of the coronoid you want to expose. And the common approach that I commonly use is a posterior midline approach that gives exposure on both the medial and lateral side. Can you treat terrible triad non-surgically, yes, in a very rare cases, very few cases, provided you have very good concentric joint after the reduction, the radial head is moving without any obstruction, and coronoid is classically a small tip of the coronoid without any capsular attachment, and you are able to get a stable and concentric range of movement up to last 30 degree. So that, but the caveat is you should be keeping the patient under weekly follow-up and brace and start early active range of movement. So when to start mobilization, that's another thing. The newer things is that this is a paper from Andrew Druckworth which says that you start early active mobilization, because when you start early active mobilization, your muscle starts acting, the dynamic stabilizer start acting, and it closes the space. So start early mobilization of all the cases where it's treated, and avoid mobilization in varus. When you mobilize in the varus with humerus in abduction, with the humerus in abduction, you are stressing the lateral collateral ligament. So never mobilize with shoulder abducting. So that position, because that stresses your lateral collateral ligament. So that should not be done. Okay, so start early active range of movement in a congruent joint and avoiding abduction of the shoulder. And what's the influence of gravity? The gravity increases the joint space. So as you can see, the advice is to start against gravity. So the gravity assists you move. So in supine position, start moving with the gravity assisting in the reduction. So that's the position. Another thing you have to keep in mind is that you have to avoid heavy slabs or heavy cast, because if the patient is on a heavy slab or a cast, that will aggravate the joint space, or that will aggravate the instability. So always use a light slabs like that, or light LTTP splints you can use, and start mobilization in pronation. So what I do is that usually a thin slab, elbow in 90 degree, forearm pronated if there is an LCL injury, start flexion extension up to 45 degree. Don't go beyond 40 to 45 degrees. So that is a safe position up to 2 to 3 weeks. Okay, and pronosupination in 90 degree, and splint is removed by around 3 weeks, and you start strengthening by around 6 weeks. This is one of the case examples. As you can see, this is the midline incision, and patient has got fairly good movement. So what is the goal of our treatment of cerebral triad? The goal is to get a stable, congruent and concentric joint which may be somewhat stiff. It is much better than a joint that is unstable, mobile but unstable. So this shows a non-untreated cerebral triad that gets in the posterolateral instability. You can see the radial head jetting out, and the treatment would be reconstruction of the LUCA. And after the LUCA reconstruction, you can get relatively good movement. But that's what you want to avoid. So to conclude, cerebral triad is a spectrum of injury. All the elbow injuries are not cerebral triad. You should understand each fracture, which one is cerebral triad. Always assess with the CT scan the position of the radial head and the coronoid. Never exercise radial head acutely. If you are aim for a stable and congruent range of movement up to last 30 degrees of extension. And then it's safer, whether it is surgically or non-surgically. Stabilize both the soft tissue as well as bone. So not only coronoid and radial head, but your lateral structures is equally important. And start active range of movement, avoiding varus and avoiding gravity. So proper rehab is a must. Then only you will get a better outcome in a cerebral triad. Then it becomes not so terrible. Thank you.
Thank you, sir.